Welcome to It's Your Case, presented by VetCT.com. I'm Amy Zaltzman, your radiologist on demand for this week. We continue this month's theme of pulmonary patterns. It's time to take a breath. Our journey continues through the four broad classifications of pulmonary patterns. As a reminder, it is always important to keep these findings in the context of the patient history and exam. A short commentary is included after the case about the pattern. Today's example is an 11 weeks old male intact domestic shorthair presenting with dyspnoea. He was adopted 3 weeks ago with a litter mate. There are other animals in the home, but the kittens are separated by a room. Starting approximately a week ago, he became lethargic, he wasn't eating and not moving as much. He had a change in the quality of his breathing, which appeared as a bump on the side of his ribs. Trauma is not known but cannot be explicitly excluded. There was also spray painting in the room where the kittens are now housed, but that would have been less than 2 hours exposure. He continued to worsen. He has not been vomiting, but he hasn't been eating. He's not had diarrhea and has barely touched any food. The client did get a can of AD, but he has not eaten it. He presents in respiratory distress. An IV catheter has been placed and IV fluids have been started. Vitals include a weight of 1.1 kilos, a heart rate of 187, a respiratory rate of 160. He's dyspneic, quiet, alert, and responsive with a blood pressure of 142/113. He is dehydrated and in shock. He has upper respiratory congestion with referred sounds to his chest. He has muffled, harsh lung sounds that obscure adequate auscultation of his heart. His PCV total solids are 40% and 6.2. His chemistry panel is unremarkable. His CVC has a normal white blood cell count and normal platelets. His proBNP is high normal. His dyspnea has improved with oxygen therapy and resulting in a respiratory rate of 85 respirations per minute. He has now eaten kitten food with a good appetite. There is a severe, generalized, unstructured interstitial pattern throughout the pulmonary parenchyma. Additionally, we see that there is an ill-defined bronchial pattern throughout the same distribution, resulting in an overall reticular appearance. This is associated with partial border effacement of the pulmonary vasculature. Making them difficult to assess. The lungs are moderately overinflated, resulting in mild flattening of the diaphragm and increased separation of the cardiac silhouette. On the ventrodorsal view, there is mild horizontalization of the ribs as well. The cardiac silhouette is mildly and generally enlarged without clear specific chamber enlargement. The thoracic portion of the trachea is mildly dorsally deviated and slightly dilated. It has an uneven diameter and slightly irregular undulating borders. There is no visible intraluminal material. Our conclusions for this patient are severe interstitial and bronchial lung pattern. Additionally, we have cardiomegaly, which may be age-related. However, a congenital cardiac disease or pericardial effusion or cor pulmonale cannot be entirely excluded. There is mild tracheal flaccidity, which might be secondary to the age and dyspnea. The pulmonary pattern is evocative of a severe interstitial lung disease and possibly small airway disease, such as bronchiolitis. These comprise multiple etiologies, including toxic pneumonopathy, which would be a concern given the history, but also infectious causes such as viral, bacterial, or fungal. The latter seems less likely given the normal white blood cell count. Both scenarios can lead to irreversible fibrotic lung disease, which is usually requires a pulmonary biopsy in order to confirm this type of lesion, but may not necessarily recognize the underlying etiology. Computed tomography of the chest can also be useful to better assess the pulmonary lesions, but also, again, may not provide a specific etiology. Echocardiogram may be considered to completely characterize the cardiac chambers to rule out the potential contributing component of a congenital cardiac anomaly. As discussed last week, interstitial patterns can encompass a large range of manifestations from unstructured to structured diseases. Unstructured interstitial pattern commonly refers to increased opacification that incompletely obscures the margins of the vessels. The vessels are still visible as structures, but may have diminished sharpness of their margins, as we see in this dorsiventral view. The distribution in conjunction with other pulmonary patterns helps prioritize the differential list. Caudodorsal distributions are often typical of pulmonary edema. This can be cardiogenic or non-cardiogenic, such as ARDS, SIRS, electrocution, near drowning, seizure, etc. Cardiogenic pulmonary edema would be favored with concurrent hypervascular pattern, as this would potentially indicate increased hydrostatic pressure. Cranioventral distributions are more commonly observed with pathologies introduced via the airway, such as bronchopneumonia. One might expect a concurrent bronchial pattern in these cases. Be sure to view the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.